You have a 34-year-old male patient who presented following a road traffic accident. Abdomen is tense and tender in the right upper quadrant. I'm not going to ask you again what your initial management is, pretty much the same thing, but what's
So,
your main focus in the initial management?
circulation. So I'd say you need to manage this patient according to ATLS protocol. My main concern here would be that of circulation. I want to know the blood pressure of the patient and the classify hemorrhage or focused abdominal examination. To find if there's looking for bleed on the floor and 4 or more, stop any external bleeding with compression, and insert 2 wide bore cannulas and start fluid resuscitation. Take some bloods, including the group and save and cross match. Commence the patient on IV fluids, and then give a blood transfusion if they're not responding to fluids.
Sounds really good. You have an X-ray. Could please give me a comment on that X-ray?
Yes, so this is a AP radiograph of a unidentified individual at an unidentified time. The most obvious abnormality is that there is a left-hand-sided pneumothorax with associated surgical emphysema and a rib fracture as well.
Yeah, just getting it. So left-sided pneumothorax and emphysema with rib fractures. And how would you manage this condition?
So I'd manage this condition according to protocol. I'd want to do a thoracotomy followed by a drain insertion. This would be done by the safe triangle, just within the 5th intercostal space and mid egg line.
What is the type of shock in pneumothorax?
The type of shock in pneumothorax would be obstructive shock.
And there is a CT scan here. Could you please comment on
This is a axial CT scan of the abdomen. It shows a
needle thoracotomy was successfully done and blood pressures is still very low, tachycardia, pale patient, and the CT is as above. What's your next step?
So here I'd want to manage the patient according to CRISP protocol. I'd want to classify the shock. I'd want to stop any obvious bleeding at the source. I'd want to insert 2 wide bore cannulas into each antetubercle fossa and take a group and save and cross match 4 units of blood. I'd start with resuscitation of IV fluids. So I'd give 1 litre of crystalloid. And if the patient wasn't responding, I would consider triggering the major hemorrhage protocol. Other adjuncts I'd consider here is giving TXA, related to the general surgery on call for potentially the patient to theatre.
What's the dose of TXA?
The dose of TXA can be 1 gram or TDS IV.
Okay. Is there any type of patient that will give 2 gram, not 1 gram?
Typically, patients due to go to theatre, we can give 2 grams to, or prophylactically with unstable or acute drop in HB, or trauma patients as well. So here, this patient, this patient, I would give probably 2 grams.
Yeah. So if you have any patient that is code red or code black, I'm not sure how you classify it in your hospital, but basically any patient who's going to an operation. Code black is a neurosurgical patient who's going for an operation. Code red is any other patient who's going for an operation. Okay. Yep. Only those 2 patients will give 2 gram. All right. Yep. Otherwise, you can give 1 gram.
Yep. Sorry.
All right. Right. What are the grades of liver tear?
So the grades of liver tear can be based findings or based upon clinical findings. So grade 1 is where we have a confined subcapsular. There's 6 grades or 5 grades depending on which classification. The 5 grade classification is where so grade 1 is where you have a hematoma, which is less than 10% of the surface area, or a laceration, which is less than 1 centimeter. Grade 2 is where the hematoma is between 10 to 50%, or the laceration is 1 to 3 centimeters. Grade 3 is 50% of the surface area of the hematoma, or greater than 3 centimeters. And then grade 4 and 5 are the ones that we're most worried about. So this is where you have hepatic lobe involvement. So grade 4 would be up to 75% of hepatic lobe involvement, and grade 5 is where we get over 75 hepatic grade involvement.
And how would you manage liver tear?
So I would manage liver tear according to ATLS protocol. The management would be that of conservative. So here I'd want to do a blood transfusion and the hemodynamic status of the patient. And then if this patient was unresponsive or I was clinically worried about the patient, I would consider surgical management, which is packing the liver. So we can do perihepatic. We can either do repair of the liver, or in certain instances, in severe cases, so grade 5 and above, we can do resection.
Okay. CT scan the right investigation to do at this stage?
In this patient, no, just because the patient was hemodynamically unstable. I would consider doing a scan, first investigation, to look at the 4 quadrants, so the perihepatic space, the splenic space, the cardium, and the pelvis. The the CT scan would have been the right investigation if the patient was hemodynamically stable. However, in this instance, no.
The areas to examine using a fast scan.
So we can look at the perihepatic space, which is the Morrison. You can look at the space, the pericardium in the heart, and also the pelvis as well.
Okay, great. All right. Excellent. Very good answer here. Specific comments. The only thing I would say is, which I noticed here and in the previous scenario as well, when you're being asked a question that's not in the notes, I think you tend to, I don't know, but I think the answer is not as well structured, other, which is understandable. But what I would say is you will definitely be asked questions that are not in the notes in the exam. It's not going to be many questions, maybe one or two questions maximum. All right. Just invite, and if you don't know the answer, just skip the question from the beginning.
Okay.
All right? So you would give an impression that you've given a very good answer for each question. And then at the end of the scenario, when you have more time, when you know that you have more time, you will be asked again the same question and you will have more time to think about it.
Okay.
So someone is asking, can you go over through the TX8 dosing? If you have TX8 dosing, you have a patient who is polytrauma, you need to think about it, one of two things. Okay? You can give 1 gram or 2 grams if your patient is going to theater. 1 gram if your patient is not going to theater. As simple as that. If you have a suspicion that your patient is going to theater, so let's say you have a patient who's coming with a very obvious head injury, was assaulted and hit on the head by a baseball bat. Okay? Coming to resuscitation with GCS of 8, intubated, and hasn't had a CT scan yet. How many of you think that this patient is likely to undergo an operation? With this significant head injury, very likely they would go for an operation. So you would give 2 grams of the TXA. You have a patient with, is very tense and tender and distended after a road traffic accident. That's likely an intra-abdominal bleed, and they will require to go for a laparotomy. You will give 2 grams. Okay. The other side, if it's like trauma, but low mechanism of injury, patients coming GCS 15, you don't think that they will undergo an operation, you give 1 gram. All right. Someone was asking what's the rib fracture. Obviously, the quality of the X-ray that we have here is very poor. All right. It's where the arrow is, but obviously, if you're on PACS or your system that you use for you'll be able to change the contrast and you then be able to find the rib fracture. But in this one, it's very difficult to point to you where is the rib fracture.